Welcome to Sound Bites, hosted by registered dietitian nutritionist Melissa Joy Dobbins.
Hello and happy February. February is American Heart Month, so I wanted to share this episode about omega-3s and cardiovascular health, especially because it addresses some of the controversy and misinformation about this topic. And I'll also be sharing an episode about omega-3s, brain health, and concussions. And I really enjoyed interviewing today's guest, Dr. Carl Lavie. He's a board-certified cardiologist. You might notice a few audio issues on his end just toward the beginning of the interview, although my audio editor did a phenomenal job of minimizing these issues. But I wanted to tell you why we were having trouble because I got a pretty big laugh out of it. When I interrupted him to let him know that I was hearing this noise with his microphone, he told me that he was still wearing his stethoscope, and the microphone was rubbing up against the stethoscope. And I thought, oh my gosh, only a doctor would have that kind of an audio issue. But I really hope you enjoy the episode, and be sure to stay tuned afterwards for an announcement about the winner of the Longevity Diet Prize Package giveaway from Prolon, Nutrition for Longevity, and Fast Bar. Hello, and welcome back to the Sound Bites podcast. I'm your host, Melissa Joy Dobbins, a registered dietitian nutritionist. And on my show, we delve into the science, the psychology, and the strategies behind good food and nutrition. And today's show is all about omega-3s and heart health. My guest is Dr. Carl Lavie. He's a board-certified cardiologist and currently professor of medicine and the medical director of cardiac rehab and prevention and the director of the exercise laboratories at the John Ochsner Heart and Vascular Institute, the Ochsner Clinical School, the University of Queensland School of Medicine in New Orleans. That is quite a title, Dr. Lavie. Welcome to the show.
Thanks for having me, Melissa.
Now, you have authored over 1,000 medical publications, 2 cardiology textbooks, and you serve on 40 different editorial boards. I don't know when you have time to sleep, but I'm really interested in hearing about the current research on omega-3s and cardiovascular disease. And I understand you also have expertise in exercise. And you also authored the book, The Obesity Paradox, which sounds really interesting. So I'd like to touch on those topics as well.
That'd be great, Melissa.
Could you tell us a little bit more about your background and really why you became so interested? I mean, you're a board-certified cardiologist, so it makes sense that you would be interested in omega-3s. But I'd love to hear a little bit more personal and specific about what it is that really got your attention on those.
My main interest is in preventive cardiology, trying to prevent cardiovascular disease in the first place. And in a majority of the patients that I see in the office every day is to try to prevent the progression of their disease when they already have disease to begin with. And so these are all areas that are very important to preventive cardiologists. Omega-3 is a simple thing. Omega-3 is fish oil. And many of my patients really like the idea of doing natural things and not just relying on prescription medications. Now, the fact is, most of my patients need to be on prescription medications for blood pressure, for cholesterol, like the statins, and many other medications. But they really like the ideas of doing some of the natural things. And omega-3 is something that is very natural and also combines well with very low toxicity or side effects with almost all the other therapies we use in the medical field and in preventive cardiology. So I actually became interested in omega-3 and fish oil therapy many decades ago. In fact, published papers on omega-3 over 30 years ago. And this has been a topic that has been around for a long time, and certainly studies done 30 years ago were extremely impressive showing big reductions in clinical events. For example, there was one called Gisi Prevenzione in a large study of patients after heart attacks that showed that about 1 gram per day, or 1,000 milligram per day of omega-3 in the form of what's now been a prescription agent. It was called Omicor then and has lately been called Lovaza, which has 840 milligrams of combined EPA and DHA. And EPA and DHA are the abbreviations for icosapentaenoic pentanoic acid and docosahexaenoic acid, that showed tremendous prevention in clinical events and mortality in patients after heart attack. The problem is, though, that during the past 30 years, we've developed many other therapies that have been very effective. Better blood pressure agents, better agents for diabetes. The patients after heart attack are treated with very strong blood thinning medications. They usually in the United States are revascularized. They get a stent generally with their heart attack. And they're on high doses of statins. And with all of these other therapies, the role of omega-3 has become more controversial because many of the studies didn't show additional benefits of adding omega-3 to all of these other therapies. And so there has actually been controversies about omega-3 in the last decade or so, where many of the more recent studies have not demonstrated the same benefits as the studies done 30 years ago. But there have been now very recent studies that have been very impressive regarding the omega-3. And if you'd like, I can discuss the results of some of these recent studies.
Yeah, that would be great. So, and I'd love to hear your insight as to why, was it how the studies were designed, or like you said, with these recent developments, was it just in comparison they weren't as effective? But it sounds like you said that the newer research showed that the omega-3s weren't as effective as the previous research. I know that you shared a meta-analysis with me, but yeah, I'd love to get your insight.
Yeah, so some of the studies done over the last couple of decades, many of them have been done, they've either been underdosed, they haven't been powered enough to assess clinical events adequately. For example, if you use a very low dose of omega-3 in a population that has a low risk of having cardiovascular events during a short follow-up, it's not going to be very likely you're going to be able to show benefit. And then even in patients after, for example, heart attack, compared to 3 decades ago when the patients with heart attack were not treated so vigorously, now they're treated extremely vigorously with 2 blood-thinning medications, high-dose statins, and many other pharmacologic agents. They've already gotten a stent for their blocked artery. They recommended to go to cardiac rehabilitation therapy. And so when you add on omega-3 to all of these other therapies, which have already reduced their risk tremendously, it's hard to show additional benefits. So there have been a number of studies that have suggested that the omega-3 was not producing nearly the benefit that it produced in studies 3 decades ago. And there have even been meta-analyses. Meta-analysis means that you put the results of many studies together that have also said that the meta-analysis came out negative, showing no additional benefit. Well, for example, and that's been in the press a lot, and not just for clinicians, but to the lay public. And some of the meta-analyses that have been said to be negative actually were showing 10 and 15% reductions in major events. But some of the meta-analyses designed their statistical analysis to where they set the bar extremely high and higher than what we usually do in studies. And just for example, I know most of the audience are not going to be statisticians, but generally we set the statistical significance at a level of p less than 0.05, which means that there's a 95% chance that what you're seeing is not just by chance. Well, some of the meta-analyses have set the statistical bar at 0.005, meaning that there is well less than a 1% chance that the results could be by chance. And so they've set the bar way, way higher. And so they ended up ignoring 8%, 10%, 15% reductions in major cardiovascular events, including cardiovascular mortality. So it's one thing if you set the bar very high for a therapy that's got potential risk. Like if you're inserting a device into someone that costs $150,000 to insert and it's got risk of causing harm, well, you want to really be absolutely sure that you're not getting benefits that just were chance benefit. Or you really want to get 25 and 30% benefits if you're going to be using potentially toxic therapy that's very expensive. The difference is with omega-3, it's one, very inexpensive, and it's got virtually no significant toxicity. And so when I'm thinking about the potential to even reduce events by 8, 10, 15%, well, that doesn't seem so bad when you're dealing with something that's inexpensive and non-toxic and combines well with everything that we do. And I've seriously questioned the interpretations of some of the studies that have been reported to the public and to the clinicians in the last decade or so. Well, we have recently published a big review article that just came out in the past month in the Mayo Clinic Proceedings. And the Mayo Clinic Proceedings is a very prestigious medical journal that's highly rated and has a readership of over 130,000. And in this article, we reviewed 3 very recent papers. One was a study called the Reduce It trial. It was a study done in 8,179 patients that were given Vasepa, which is a prescription omega-3 called just pure eicosapentaenoic acid, or EPA, versus placebo. In addition to statin therapy, so that all the patients were on statins and they either received 4,000 milligrams, which was 2 capsules twice a day of the Vasepa, in addition to their therapy. And this addition ended up producing a 25% reduction in major events with a number needed to treat of only 21 patients to reduce one event. It reduced cardiovascular death by 20% and sudden cardiac death by 31%. So tremendous benefits on top of statin therapy. So it's hard to show benefits on top of statin therapy, but with this high-dose prescription omega-3, there was very substantial additional benefits. And there's been no therapy to date that when added to statins has produced this type of benefit as this prescription omega-3. Well, there was 2 other big trials. One was the Vital trial, which was done in 25,871 participants who didn't have cardiovascular disease, and they used just 1 gram of prescription omega-3. It's called Lavie. But this is a prescription that basically you can get the same thing in over-the-counter or non-prescription omega-3. It's a 1,000 milligram capsule that contained 840 milligrams of combined EPA, DHA. And so you can find capsules that have approximately the same EPA, DHA over-the-counter. Well, this study only showed an 8% reduction in events, and it was statistically not significant. But there was a 17% reduction in coronary heart disease death and a 28% reduction in myocardial infarction or heart attacks. And these results were statistically significant. Also, they showed in the patients in this trial who were very healthy to begin with, who consumed less than 1.5 fish meals per week. And in my experience, the majority of Americans consume well less than 1.5 fish meals per week on average. I like fish, so I eat fish more often than that. But the majority of my patients don't eat fish that much. Many of the patients don't eat fish at all or eat fish once or maybe twice per week. And then when they're eating fish, they're very often eating farm-raised catfish. And I like to say that farm-raised catfish is basically like eating a chicken with gills. It doesn't really have much omega-3. And they showed in this paper that if the participants were eating 1.5 fish meals per week, they actually got a 19% statistically significant benefit on their major cardiovascular endpoints and a 40% reduction in their risk of heart attack or myocardial infarction. So for many of our patients, if you applied these results to a low fish eating population, they could be tremendous benefit of just this fairly low dose of omega-3. And so that's the second study. And a third study was done called the Ascend trial. It was done in 15,480 patients with diabetes. And they used exactly the same thing, 1 gram of the Lovasa, which contains 840 milligrams of EPA and DHA combined, something that would be easily done with over-the-counter or non-prescription omega-3. Now, this trial only showed a 3% reduction in the major endpoints, and so they discounted this trial as being negative. Yet, the trial showed an 18% statistically significant reduction in cardiovascular death. So that's, I think, a pretty important endpoint, again, for a therapy that's got very low cost and low toxicity. So I think that there are 3 major studies just done that showed pretty significant benefits. And then just in the past month or so, there was a big meta-analysis that was done in the journal JAHA, Journal of American Heart Association, by pretty famous people in the Harvard area. 2 of the authors were named HU, and the other one was Joanne Manson. And this study analyzed well over 100,000 participants and basically showed about 5 to 10% reductions in major cardiovascular events, particularly coronary heart disease events, in patients who were randomized to the omega-3, and showed benefits were even more so if they took higher doses. So there's been several recent studies that have been published that I think really do support omega-3, not producing 50% reductions in events, but more like producing somewhere 5 to 10 or maybe as much as 20% reductions in events in patients who are not consuming a background of much omega-3 or fish consumption to begin with. And so I think that the public has sometimes been hearing headlines that have been misleading. I've heard headlines, and some doctors have sent me a note saying, I just read this, that they said fish oil is not helping patients. And I think this is totally untrue. I think that the majority of evidence is not showing 50% reductions like we often want to see with expensive prescription therapies, but we're seeing some pretty nice reductions for a therapy that's very inexpensive, that has very low toxicity.
Wow. Fascinating. You mentioned, you're basically in some of these studies, you're talking about a dose response, right?
Right.
And when you said that P less than 0.005, I was expecting you to say 0.01. So I was like, what? 0.005?
0.005 is actually way less than 0.01. And 0.01 would mean there's a 99% chance the results you see are accurate. And I actually said 0.05, but it's actually 0.005.
Yeah, no, I think you did say 0.005. Yeah.
That's a way stronger statistical significance than we typically demand.
Yeah.
And like I said, almost everyone uses 0.05 because that's the standard definition for statistical significance in most of our trials. And yet, it's even better if you show p-values of 0.0001. Extremely high statistical power. But the thing is, normally we don't demand that level of power. And I'm not sure why they would demand that level of power for something so simple, so inexpensive, and low toxicity as omega-3.
Yeah. Well, thank you for walking us through all of that. I love getting into the research and someone with your expertise who can really explain this is what they said, but I don't want to say if you look at it a different way, but like you said, some of this can lead to misleading headlines. Some things kind of get lost in translation, and it's really nice to kind of sort through the rubble, if you will, a little bit.
Yeah, and just for example, they'd have cardiovascular death in a big meta-analysis in JAMA, which is one of our leading world's medical journals, Journal of American Medical Association, about 5 years ago. that said cardiovascular death with omega-3 was reduced by 13%. And they said it was not statistically significant. And the p-value was something like 0.01. Like 99% chance that it was a real value, yet they called it not significant because they set the bar so high. And to me, I think they were discounting a 13% cardiovascular mortality benefit, which is not a bad benefit when you're talking about just taking some over-the-counter omega-3.
I'm a certified diabetes educator, and so I'm very familiar with the ASCEND trial. And when you're thinking of course, people with diabetes are at increased risk for cardiovascular disease, and anybody with all of these comorbidities, or, it's they got the blood pressure, they got the cholesterol, the metabolic syndrome, all of these things, sort of this cocktail, if you will. We need a lot of tools to address all of these different pieces. And, to your point, with something like omega-3s, and we're going to touch on diet and then more specifically about supplementation moving forward here. But like you said, if it's something that's safe and inexpensive, every little bit, I think, counts. And it sounds like in some of these trials or the research studies, it was more than a little bit.
Yeah, just for example, in the ASCEND trial that you just mentioned with diabetes, the patients were treated vigorously for their diabetes. They were on good therapies for blood pressure and cardiovascular protection, and they were on typically statins. And so the omega-3 was added on top of all of this. And generally the patients that enter trials are generally more healthy than people who we see in the office who are not the ones entering the trials, who generally have higher risk. And still, in that trial, there was a statistically significant 18% reduction in cardiovascular death, which I think is a pretty important endpoint.
Right. Yeah. So sort of like the dose response when you're looking at where that person is on the health spectrum. Like you said, if they're eating less than 1.5 fish meals a week, they tend to benefit more. If somebody, just like with diabetes, if somebody has an A1C of 13, some little changes could really help bring them down significantly.
Correct. If they have an A1C of 6.5, it's going to be harder to show additional benefit.
Right. And I know that you had mentioned prevention when you first started talking about your career and your interests. So I know, like with the research studies we've been talking about, a lot of this is on the treatment side. And when we're looking at prevention, of course, we're looking at diet and supplementation and lifestyle factors. Maybe somebody, is on a statin or something like that in the form of prevention, but it's a little less of this cocktail that I mentioned with, all of the pieces. But a quick comment back to the research studies is, like you said, when you're adding the omega-3s on top of all these other things, and it is kind of hard to, control for the other pieces and just look at the effect of the omega-3s. So maybe now would be a good time, and we can still kind of talk about the research and pepper that in whenever it's needed, but shifting to more of the prevention. And also, I guess we can also talk about treatment, but let's talk more about people day to day. I know that almost 95% of Americans are not getting enough EPA and DHA omega-3s. As a dietitian, I have some ideas of why that is. I think it's multifactorial. But if you're talking, you see patients all the time. Like you said, most people are eating less than 1.5 fish meals per week. Why are we not getting enough? Is it partly a knowledge? Are people confused about omega-3s? Or they know they should be eating fish, but they don't have access to it? Is it it's just our culture? We're not big fish eaters. What would you say with all the patients that you see on a regular basis?
Certainly, it's not all just one reason. Certainly there's a lot of people that don't like fish, that don't like the taste of fish, they don't like the smell of fish, they don't like the fishy taste. Other people find fish to be more expensive. For many people, the fish isn't readily available, and then the fish that is readily available, as I mentioned before, is the farm-fed catfish, which really is giving very little omega-3, and I used to joke a lot of times that a farm-fed catfish is like eating a chicken with gills because you don't have much omega-3 in it. And really, to get the omega-3, you need to be eating salmon, tuna, herring, mackerel, sardines. That type of fish is going to have higher omega-3. And that's not what typically people are eating on a regular basis.
Right. Good point.
To get the omega-3, if you're not eating it, I'm all for it. If somebody's going to have a couple of fish meals per week of the good fish that have a good amount of omega-3, well, then that's fine. If somebody's having 2 or 3 fish meals per week with omega-3, they can have pretty good levels of omega-3 without taking a supplement. But for many of the patients who are not taking the good amounts of omega-3, particularly if they have higher risk, if they have higher cholesterol, if they have higher triglyceride values, and if they're not in extremely good overall health, they would get benefit by taking about a gram per day of the combined EPA-DHA, where they're at least getting, the amount that's in these studies of the Vital and the Ascend trial, where they are getting close to a gram per day of the combined EPA-DHA. And actually, the amount in those 2 trials was 840 milligrams of EPA-DHA. And that's the important thing, is that people have to look at their capsules to know how much of EPA-DHA is in it. And so some of the inexpensive omega-3 might have 1,000 milligram capsule, but it might only have 180 of EPA and 120 of DHA, so a combined 300 milligrams of EPA-DHA in the 1,000 milligram capsule. That means to get close to the amount that you need, you'd have to take 3 capsules a day.
Exactly. Gets confusing.
Yeah, you don't want to be taking 3 capsules. And for the majority of the patients that I'm seeing, their weight's high. And so even though there's only about 10 calories per capsule, they don't need any excess calories. So it'd be better to get a capsule that's more concentrated. And so the ideal would be to get that much omega-3 in just one capsule, to have over 840 milligrams, getting close to 1,000 milligrams of combined EPA-DHA in just one capsule. Sometimes that's hard to find. It's very easy to find capsules that have 600 milligrams of combined EPA-DHA in the capsule. And then with a 600 milligram capsule, you basically would need about 10 capsules a week to average the amount. Or somebody could just take 2 capsules a day, because there's no harm of getting extra. Of having 1,200 would be fine. Like I said, the only thing is that it does have some calories in it. It's not many, just 10 calories or so generally in a capsule. But for people who are carrying, a lot of excess weight, really they don't need any excess calories. So really, then if they just took 10 a week, one most days and occasionally a second, or they could just take 1 daily if they're getting, a fish meal.
Right.
So that at least they're averaging the right amount of omega-3 in their total dietary consumption.
So it sounds like, from what you're saying, there are some people who don't need supplements. They can do great on a high rich omega-3 fish source diet.
Eating tuna fish, for lunch, several times a week, or having a couple of salmon meals per week, or somebody going out and eating sushi a couple of times per week, or maybe eating sushi once and eating salmon once and eating some tuna fish, another time. Well, they're getting a lot of omega-3 in the diet. But as I mentioned earlier, my experience is that that's not what people in the United States are doing.
So I know the recommendation is, to aim for about 2 servings of fish a week. Would you think it would need to be a little bit more if you're not doing any supplementation?
I think the perfect would be probably 2 or 3,
fish
servings per week. But if someone is clearly getting 2 servings per week of the good fish, the fish that have more omega-3, well, that may be enough. But I think when people are going to count their fish meals, let's say they're eating trout or redfish or other types of fish that have some omega-3, certainly more than farm-fed catfish, but not nearly as much as, say, salmon and tuna.
A little range there.
Unless somebody's going to measure out their grams of fish and exactly how much omega-3 is in their serving sizes. And I think it's not practical for most people to really do that. If somebody's really studious, and you would do that as a dietitian,
maybe,
but that's not what most people are doing in their lives. They're not sitting, certainly they don't measure the size of their piece of meat or their piece of fish.
No.
And so then they're not going to want to look up what's the difference between redfish, trout, and tuna and salmon and the total amount of EPA, DHA. And so I think that for many people, I'd like to say they probably should be trying to get 2 or 3 fish meals per week, not counting catfish. And if they're doing that, they're getting a pretty decent amount in the diet. Like I mentioned, I think my experience is that would be a real minority people
Right.
that I see in the office that are eating that much fish. And I live in New Orleans, too, where we have plentiful seafood.
There you go.
Most people in the United States don't have the access to the good seafood that we do, and certainly many people are eating mostly chicken and red meat, and they're not getting any omega-3s from that. And so they need to get it then from the supplements.
Right. I was just thinking, this is sort of a side note, but some people say, well, grass-fed beef is higher in omega-3s. I'm like, it's not a good source of omega-3s.
Correct.
Let's just look at the fish. And we're going to talk a little bit about plant versus seafood sources in a minute. But before we move on from that topic, though, if somebody might be more at risk, like you had said earlier, do they potentially need more, or they're going to really want to be more cautious about, if I'm not getting this in my diet, I really need to look at a supplement? Or should we all have that approach, whether we are at risk or not?
So again, for patients who have really high triglycerides, now just in the past week, Vascepa has now got an official FDA indication for people with triglycerides above 150 to be used in addition to statin therapy. But the dose is high. It's 2 grams twice a day, so it's 4 capsules a day. So, I mean, again, I think patients would have to get this as a prescription anyway from their physician, and the higher risk patients would really benefit from this prescription agent. Most people are going to be using this outside of prescription, and they're going to be using over-the-counter non-prescription agents. And so for the patients who have a little bit high triglycerides or high cholesterol values, they may not be able to reproduce the Vascepa results, but just getting a gram per day has been shown to produce significant additional benefits. And if someone wants to take 2 grams per day, you're probably going to get even more benefit from higher doses. But I think that the majority of patients are going to probably be more willing to be taking about 1 gram per day, which is getting over 840 milligrams of the combined EPA, DHA per day.
Okay. I should mention that I did a podcast interview, number 74, with Ellen Schutt from GOED, which is the Global Organization for EPA and DHA Omega-3s. And that episode, it was called, Are You Getting Enough Omega-3s? I'll link to that in the show notes at soundbitesrd.com if anybody wants to go back and listen to that one as well, because we talk about, are you getting enough? How much, kind of breaking down the EPA and DHA. I like the way you say, just looking at combined at least 840, I mean, just shooting for that 1 gram a day. But are we moving toward the approach where maybe people would be getting their omega-3 levels checked? I know I had the opportunity to do that through GOED a couple of years ago, and it was really interesting. What are your thoughts on that as a cardiologist?
I think that if you're not eating fish regularly, if somebody's eating 0 fish meals per week or 1 fish meal per week, you're going to have low levels.
You're just going to know that, yeah.
You know that before you even test it. And so the average person in the United States has a level which is, if you measure it in the red blood cell membranes, it's like 4%. In Japan, the average level is double that at 8%. Mm-hmm. Realize the average person in the United States, there's going to be some that are going to be eating, fish regularly. Majority are going to not be eating fish regularly. And so probably those who are not eating fish regularly probably have levels like of 2 to 3%, really low levels of omega-3, whereas the person who's eating several fish meals per week is more going to have levels like the Japanese who eat more fish, and they may have levels of 6, 8, and 10. If somebody's eating sushi and fish 3, 5 meals per week, they're going to have levels even above the average Japanese. And so, again, if you're uncertain, you can have your level checked. It's not considered a routine test. It's not often covered by many of the insurances, but it is something that can be done. And again, if someone's uncertain about their level and wants to have it done, it is a test that is available. It's just a prick of the finger. They take 1 drop of blood and they can measure your omega-3 blood levels and tell you about where you are. You'd like to have levels of closer to 8, but you certainly want to have levels well above the 4 level that is present in most Americans.
Oh, that's very interesting. And that's a good point. Most people are going to be low. I found it interesting because I luckily have a really good blood lipids. My cholesterol has always been great. My HDL is nice and high. Triglycerides are beautiful, everything. But I was low on the omega-3s, and I do work on getting my seafood twice a week, and my family as well. So yeah, that's interesting. Thank you for addressing that.
Yeah, and Melissa, honestly, omega-3 is probably good for everyone, but I'll make the point is if you have low risk and you have beautiful lipids and you're healthy to begin with, you probably need the omega-3 less than most of my patients that I'm seeing who don't have perfect lipids and have a bunch of other risk factors as well.
Well, that's good to know. There is a certain person in my immediate family who definitely needs these. And we go back and forth, as far as staying consistent. Just as a little side note, because I think it's always about figuring out the barriers to healthy behaviors. And we had an interesting conversation last night. This person will remain nameless, but people can probably figure out who it is. The thing that I'm going to do to help this person take their supplements is to put the pills in the little weekly pill thing. They just don't want to do that. And I'm like, I'll do that for you. That's easy, but
I think we have a lot of significant others that are regularly doing that for my patients, and some people need help organizing their medicines. And many of my patients, they don't want to be on more medications, and they certainly don't want to be on more prescription medications. My experience, though, is that they don't mind nearly as much being on supplements.
Absolutely.
They don't consider a fish oil a medication. They consider it like something natural.
Absolutely. Yes. And, I talk a lot about behavior change and real life on my show. And okay, so you're right. It was my significant other. It was my husband. And, he said, I know it's stupid. I just don't want to do it. I said, it's not stupid. That's reality. This is what we do when we try to get to the nitty gritty of behavior change. I'm happy to do your, and now I could put these pills in here for you, and then you might find that, you still forget or you need reminders or whatever. But this is how we get to actual behavior change.
I know many wives are doing that for their husbands in my practice, and occasionally it's husbands doing it for their wives. It's more likely vice versa, but it is occasionally the other way too. And the fact is, it doesn't matter who organizes the medicines as long as they're taken consistently and as prescribed.
I'm happy to do it. So let's talk a little bit about the difference between plant-based omega-3 and seafood sources, both food-wise and supplement-wise. I mean, do we need both? Are they different? Or is just one more concentrated source? Because I know like with fiber in the diet, a lot of people say, well, we don't need grains. We just need fruits and vegetables. I'm like, but it's different kinds of fiber. So talk to us a little bit about that.
Yeah. So just like you mentioned for fiber, all fiber might be good for the bowels, but soluble fiber, like in the form of psyllium and oat bran, might actually lower cholesterol, whereas non-soluble, the cellulose type of fiber, doesn't lower the cholesterol. Well, for the omega-3, there is a very good plant-based omega-3, like in flaxseed oil or sometimes in other vegetables, that's called ALA, alpha-linolenic acid. The problem is, though, it takes extremely high amounts of ALA to get converted to the EPA, and very little gets converted to DHA. And the conversion is not the same in everyone, but generally only a small, very small percentage. So one usually has to take extremely high amounts of ALA to get the EPA DHA. And so there's no advantage of taking ALA over the EPA DHA. The issue comes in if someone is allergic to fish and they can't have any fish material, or they have a religious belief that they can't eat any forms of meat and they count the fish muscle as meat too. Then if they can only get their omega-3 from plant-based, well, then that's the only way you're going to get it. But if someone can get their omega-3 from fish or omega-3 supplements, there's no advantage at all of taking it by plant-based or directly by ALA.
Great. Thanks for explaining that. So let's talk a little bit about physical activity and exercise, since that's another area of expertise of yours. And of course, it goes hand in hand with cardiovascular health. So I'd love to hear, I know that you recently were speaking in Madrid on strength and exercise. So talk to us a little bit about what you're seeing in the field right now and the work you're doing in this area.
So basically right now, the federal guidelines for physical activity for adults between the ages of 20 and over, or really 20 and 80, is that all adults should be doing 150 to 300 minutes per week of moderate physical activity, or 75 minutes per week of vigorous physical activity. Vigorous would be more like running. Moderate would be more like walking or slow riding on an exercise bike or an elliptical machine. And doing at least 2 times a week of resistance exercise, which means some weightlifting. And very few people are getting this amount of physical activity. In addition, there is even evidence that sedentary behavior, which is sitting time, produces detrimental health effects that are even above and beyond physical activity. So, for example, somebody could be walking the right amount of time, but then they're sitting 12 hours a day. And right now, people, just like you and I are right now, we're sitting in front of a screen. Many people are spending a lot of their day in front of the computer, on their laptop, on their phone, on their television, playing video games, etc., and not getting much movement. And so besides people should be physically active, they also need to be trying to limit their sedentary time to well less than 8 hours per day, or at least getting up and moving about every 30 to 45 minutes while they're sitting. And so that's the ideal recommendation. Now, the fact is, though, all movement counts. And so even if you're not getting the required amounts, even any movement, even in just 1 minute interval,
like house cleaning and things like that.
So physical activity counts housework, yard work. It counts leisure time physical activity. It counts occupational physical activity. If you're working, if you're moving on your job, it counts transportation. If you're walking to work or you're biking to work, all of that counts. It doesn't have to be a formal exercise. And so all physical activity all counts, and it all adds up. So even if you're just doing it in 1 minute intervals, if you count going upstairs, if you're doing that several times a day, every time you do that, that counts as physical activity. Every time you walk from the parking lot to your office, every time you walk from the parking lot to the grocery store, to the mall, all of that walking all counts in your total amount of physical activity.
Well, I like to say, even if you don't have a device that counts that, your body is counting that. It's making that difference.
Yes. And there are devices now that you can actually easily count your steps. And the recommendations are for people to get 10,000 steps per day. And 15,000 steps is even better than 10,000. But the majority of people who are only getting 3,000 steps per day, they would get benefit if they were upped it from 3,000 to 5 or 6 or 7.
Exactly. That incremental step again. And those devices are better than they used to be. I remember when the Fitbits first came out, I got one for me and my husband for Christmas, and I wasn't really excited about it because I'm not a competitive person. And I like tracking things, but I gave up on the whole thing after it was a snowstorm, and I was actually really shoveling the snow. And of course it was wet and heavy. My husband was doing the snowblower. He got steps and I didn't get anything. And I was like, I worked up a sweat.
And somehow, maybe it was because of out in the cold or whatever. Somehow your thing was not.
The devices are better now. But back then, I think they didn't know what to do with that motion.
I think that they've been very, very accurate. Obviously, someone can cheat and be wearing it on their arm and just be moving their arm and sitting in the chair, and you can move your arm real fast, and the device thinks you're getting steps. But really, it's picking up the steps pretty good. Even on a bicycle, even on an elliptical machine, it's picking up the steps now pretty good.
That's where I'm not seeing it very good now. Like I'll be on the bike and it's really not. Or like I'll be in ballet class, but at least like I'll look and, my heart rate's 178 because I just did a combination. Yeah. But I remember going back to what you're saying about you could really be physically active yet still sedentary. And I remember when that thought first came out, and you could go running for 30 minutes or an hour and then sit the rest of the day. And that realization of, oh my goodness, yeah, that's not taking care of it.
If you really are running 30 to 60 minutes per day, most of the studies show that a very high amount of physical activity either completely or mostly negates the effects of sedentary behavior. The perfect world would be to be physically active, doing your 30 minutes per day, and not having prolonged sitting. And it's pretty easy, even if you have a prolonged sitting, to try to get up every 30 to 45 minutes. But the person who really needs to avoid the sedentary behavior is the person who's getting low amounts of physical activity. And that's, unfortunately, the majority of people in our society. I think the stats are that right now, only a little bit over 20% of men, like 25% of men, and 19% of women, and 20% of children and adolescents are getting the proper amount of physical activity. And so, obviously, these individuals need to be trying to increase their physical activity, but they really need to be avoiding the prolonged sedentary behavior, because the combination of the two is very bad.
Got it. Well, I would like the record to reflect that I am not sitting. I'm actually at my standing desk today. And I like to do my podcast standing up because it gives me more energy. And what I really like about my standing desk is that it can also be a sitting desk, because I think standing too much isn't good either. So I like to be able to move it and do both.
It can make you pretty sore if you stand in the whole day. And obviously, you can actually, even people have treadmill desk and bicycle desk. And
oh, I can't do that. I know. I would get seriously injured if I was trying to walk and talk. Oh my gosh. So I'm wondering, because I know the current philosophy in my field now is, as far as weight control, that, and I'm sure these numbers are somewhat arbitrary, but the concept of, if you're trying to lose weight, it's really about 80% diet and 20% exercise. But if you're trying to maintain weight, kind of exercise is more of the driver versus diet. Is there anything like that with regard to exercise versus diet with regard to cardiovascular health? Is it 50-50? Is it just it's all good or all bad?
I think that the majority of evidence suggests that for cardiovascular health, that the physical activity and exercise that's particularly producing what's called good levels of cardiorespiratory fitness. And you can measure cardiorespiratory fitness on a treadmill test formally, but basically the person who can walk fast, the person who can climb stairs, the person who could go out and walk, at a faster pace or jog is going to be more fit than someone who can only walk very slow and would not be able to do that. And so fitness is actually more important than weight, or another way this is termed, fitness is more important than fatness for cardiovascular health, up to an extreme, certainly up to extreme weights. If someone has severe obesity, it's very hard to be healthy. But for most people in our society right now, the fact is that in the adults in the United States, 75% are listed as being either overweight or obese by the body mass index criteria. And so for those individuals, which is the majority of our society, the perfect world would be to be thin and fit from childhood to old age. That's not at all what's happening in our society. Most people lose their fitness as they get older, and they gain weight. And the data and I've published a lot on this, actually the most in the world in the last 20 years on these topics, that most of these data suggest that the fitness and the physical activity is what's needed to produce the fitness is more important than the weight. So if someone is doing regular exercise, they're going to get their fitness to be high, and it's going to prevent them from progressively gaining weight. Now, the perfect would be to lose some weight too, but as long as you can prevent the additional weight gain. Now, if you're extremely obese, you got to lose weight. But for most of the public, they're just either overweight or just a little bit obese. And if they could prevent moving into the higher degrees of obesity, And if they did this by physical activity is a very effective way to prevent weight gain. Like you said, it only helps a little bit with weight loss, but it's a very effective for preventing weight gain. And it's the only way that you can improve your fitness, because just losing weight, if you just go on a massive diet and lose weight, one, you usually don't improve your fitness. And when you lose weight, you typically lose muscle as well as fat. And it's not good to be losing muscle. The way, if you are in a dietary weight loss program, the way to prevent losing muscle too is to be doing weight training.
Yes.
Or doing some resistance exercise while you're doing your dietary therapy.
Yes. Just because you lost weight doesn't mean you improved your health. And that brings me to your book, The Obesity Paradox. It's very interesting. I mean, this is sort of the concept of the book, but I'd love for you to speak more about the obesity paradox, what it is, what people can find in your book. It was published about 5 years ago, I believe.
2014, correct. And so the idea of the obesity paradox is that we know obesity worsens all of the cardiovascular risk factors. It worsens your lipids, it worsens your blood sugar, it raises your blood pressure, it leads to inflammation. This leads to an increased risk of cardiovascular diseases like hypertension, like coronary heart disease, like hardening of the arteries, like congestive heart failure, like atrial fibrillation. All of these are increased with obesity. Yet, once patients have these cardiovascular diseases, again, like hypertension, coronary heart disease, heart failure, atrial fibrillation, the people that I'm seeing in the office all day, every day, and most family physicians, general internists, and other cardiologists are seeing these patients all day long in their own offices, and this is most of the public, that the patients who are overweight and obese with these diseases actually have a better prognosis than do the thin patients who have these same diseases. So 30 years ago, I would have been more worried about a patient in my office who just had a heart attack, who was heavy, than I would be the person who's just had a heart attack who was thin. And actually, it's the thin person who we should be worrying about more. And that's because in our current society, where most people are not normal weight, if they develop heart disease, they are typically fragile, they're typically weaker, they have less muscle mass. And so unless they are exercising regularly and are fit, the heavier patient is actually got a better prognosis once they have heart disease. Now, I don't want to confuse people. It would be better to remain thin your whole life and fit, and then you wouldn't develop heart disease to begin with, or you'd develop much less heart disease. But for the people who already have all of these heart diseases, like hypertension, like atrial fibrillation, like coronary heart disease, like heart failure, the heavy are actually doing better. And they particularly are doing better if they're physically active and fit. So my book really makes the point that fitness is more important than fatness for long-term health. I'm certainly not trying to promote people to get fat. I'd like everyone to remain lean and fit. It's even more important to keep the physical activity high and to get the fitness higher, because fit is it.
Excellent. I remember years ago at our dietitian conference, the whole concept of fit and fat, which, health at every size is a big movement right now, but it's been around for a long time. But I really think that it's, intuitive eating, health at every size. There's a lot more talk about that now. And I like reducing the stigma, but I do think it's important that everybody has a good relationship with food and a good relationship with their bodies, a great relationship with exercise, if you will. But I'm curious, do you work with dietitians? I'm hoping the answer is yes. And, in the cardiac rehab setting and everything?
Yes. I mean, certainly, many patients benefit from dietitians. In our cardiac rehab program, a dietitian is a mainstay in the program, meeting with every patient a couple of times during the program. And certainly we typically recommend a diet more like a Mediterranean diet, which has probably the most evidence for cardiovascular protection. And for the patients who are overweight and obese, caloric restriction, and many of the patients, if they have high triglycerides and high blood sugars, really reducing their carbohydrates and especially their simple sweets is a helpful way to improve their profiles, but also helpful to lose weight. Again, to maintain weight, though, the best way to do that is regular physical activity and exercise.
Excellent. Well, this has all been great information and I think very good news overall regarding omega-3s and exercise in this obesity paradox. And just got to keep our eye on the prize about preventing cardiovascular disease and treating it properly and moving our bodies. We only have one, so we have to take care of it. Thank you so much for being on the show and sharing all this information with us.
Well, thanks, Melissa, for having me. It's been a pleasure.
My pleasure indeed. And I will have all the resources and information that we talked about in the show notes at soundbitesrd.com, including the GoEd website, which is always omega3s.com. And for everybody listening, as always, enjoy your food with health in mind and some more omega-3s and some more exercise. Till next time. Thank you to everybody who entered the raffle for the giveaway for one free box of Prolon Fasting Mimicking Diet and one free 3-day Nutrition for Longevity meal kit and 3 flavors of Fast Bar. I did the random drawing and the winner is Christina Meyer-Jacks. She's a registered dietitian, licensed dietitian, and has a master's in science. She works as a nutrition consultant, professor, speaker, media spokesperson, health and wellness strategist, and nutrition communicator, blogger, foodie, and assistant professor of nutrition at St. Catherine's University. Christina is the founder of Nutrition Up, and you can follow her on Twitter at nutrition_up and on Instagram at Spirited Table.
For more information, visit soundbitesrd.com. Music by Dave Burke.